Good afternoon. When I saw the manifest and then actually physically walked into the room, I said, wow, this meeting has been curated to bring some of my favorite people in healthcare together into one room. So it's really great to be a part of the conversation. So for folks who I don't know, before coming to now launch Care Allies, which I can tell you a little bit about, I spent a couple years at OMB overseeing HHS, and then, like my colleagues on the panel, I'm a former Medicaid director and got to work with Melanie when we were designing the duals demo in Massachusetts. So sort of thinking about some of these questions through those lenses. I actually want to connect to some extent both some feedback on the PPC framework, but also I think to the very helpful framework that Jerry Anderson from Hopkins teed up for us to think about. I think that as we think about our approach to providing access to the right kinds of social supports and some really important issues raised there, one of the challenges that we face and that I don't think we found a complete path forward on in the context of the demos is this issue around how we ensure that the non-medical services that are so important for complex populations are integrated in the right kinds of ways and how we think about the financing. But it is challenging. There's not a silver bullet to it, and I think what we've seen, certainly in the context of housing, for example, is momentum towards at least ensuring that people have a path to have better coordination with existing programs and services. And while that is not sort of meeting all the needs, even moving that ball forward, I think there's really substantial progress and actually still low-hanging fruit work to do there. So before we get to the harder questions around when and whether Medicaid will pay for housing, which when I ran Medicaid and certainly at OMB, people asked questions about, there actually is a substantial amount of low-hanging fruit, just ensuring people have access to available housing and that it's coordinated from a medical perspective as well. I think that one of the challenges we also face, and certainly Massachusetts, when we were in the process of designing the duals demo, and we talk about coordination of the medical services with long-term services and supports, and Melanie knows this well, there was on the one hand concern by folks, particularly in the disability community, that the dollars would shift from the social services and towards the medical system, one type of concern. But the other concern was just that the people who were being asked to do that coordination didn't really understand what they were coordinating. And I would always do very simple polls where I'd ask groups of physicians to raise their hand if they had ever heard of various categories of long-term services and supports, or even covered Medicaid benefits. And some of you would be surprised, many of you not at all, to know that these were not things that they've been exposed to. It's not a part of the training. There's no program around how you understand the range of services and needs there. So I think that there's additional work to do there on the social support side. And that comes all the way through to kind of how we think about the care delivery and workforce piece. So there's a proposal in the president's budget to actually tie IME dollars to better training physicians to think about value-based payment that IOM and others have contributed to the thinking around that space. I think that in a similar vein, trying to think about how we transform medical education to actually teach patients, to teach physicians, and certainly other members of the care team what it means to take care of patients with complex care conditions, but what it actually means to coordinate the care. I think that it was called out that we asked nurses to play a major role without necessarily giving them the requisite training and tools. But I think that's actually true across the spectrum. I think we don't teach social workers enough about what it means to coordinate the medical services, and certainly on the medical side, there are opportunities to improve there, the approach that we take. On the payment policy side, MACRA shows up in the BPC document. We haven't talked about it a ton today, but I can tell you one of the things we do in my company is work with providers who are thinking about their strategies for MACRA. And I think it does present an opportunity to work with those folks to recognize that this is a very different conversation around multi-payer approaches to value-based payment, and in that context, thinking about complex populations. So there's a lot of conversation on what's going to happen in Medicare fee-for-service, but as you know, in the out years, participation in commercial or Medicaid value-based payment arrangements will also count towards your MACRA targets. And I think that actually creates an opportunity as well that's worth spending some time thinking about and reflecting on in this context. I, like Melanie, am very optimistic about the potential to make sure that we are thoughtful about how we leverage lessons learned from PACE. I personally still think we could probably push the envelope and think a little bit more about how to even scale pace. And it has had some scaling challenges to date, but I think there may be some paths there that are worth exploring. Really helpful to have the conversations and feedback around the duals demos. I was interested in this idea, and I noticed that it was one of the topics that came up in the report around, have we actually optimally empowered what is the duals office or the MMP office within CMS to truly reflect both the perspective of the beneficiary and the state, or might it make sense to think about the authorities that sit there, how it's structured, different perspectives on that. But it was interesting to read what was in the report, and I think that that's worthy of further conversation. And then the last piece, and then I'll stop. I also think that this model of having a three-way contract where there is that accountability between the state, the federal government, and be it a plan or hopefully increasingly more in the future a provider, is an important one and one to continue to build on. I'll just end on the quality measure piece. I think broadly speaking, in a lot of my conversations with friends and colleagues who are on the receiving end of various value-based payment quality programs, there's often the rightful recognition that we have work to do in terms of quality measure development. And when I was running Medicaid, the conversation was frequently, why would you even consider tying payment policy to measure X when there are all these flaws with measure X? And my answer was always, in general, I was frequently in a conversation with people who actually helped develop measures. And my answer was always, we need better measures. And, that really should be an area of focus for folks who do that for a living. How do we create fora and space and provide funding so that we are evolving the measures? But the thing I would always say is, as well, most of the things that we measure and hold providers accountable for across a number of domains, shockingly, they actually get better. And so while we need better and different measures to address some of the issues that you guys have highlighted and thinking about coordination, I'm not a fan of saying the measures are imperfect, so don't tie it to payment, because we've just seen too much benefit from doing that.